welcome back, everybody. We're going to go into the GI system for this session. So we are back at it after spring break, March 23. I hope everybody is rejuvenated. I know you guys still had midterms, and you have to find a balance. Whenever there are opportunities for you to recharge and to relax a little bit, do that. And then once you are relatively charged up, you're going to have to deplete those energies again. So that is the grind. And I'll start off with a transition from the upper esophagus. We'll move our way down towards the stomach and then transition down to your small intestines. And then we'll go over the colon, primarily focusing on the anatomy. However, this is one of those topics where the physiology and anatomy go hand in hand. And I'll talk a little bit about some regulation aspects as we go through. So our story begins in the esophagus. And this is the aka food tube. So if you think about your GI system, your gastrointestinal system, what this is essentially a tube, right? From your mouth. So you eat some breakfast, or you're snacking on something in a little bit, or you're drinking fluids. That opening in the oral cavity leads all the way through this long tube that exits out the anal cavity, right? The anal and the rectal to anus, anal canal. And this entire tube begins with the esophagus, and this tube is about 25 centimeters long, again, depending on the height of the individual. And you'll see that there are several significant passages as you go through. So the first part is what they call the esophageal hiatus. This is marking right at about T10. This is the end point. And you can see there's a gap where it goes through the diaphragm and it passes through. This tube normally is collapsed. Unless you're eating food, or unless you have a food chunk, and the mash of food that you chew and you swallow is called a bolus, B-O-L-U-S. So bolus is that food mash product that then is auto-rhythmically squeezed through the tube. It's going to pass through this region called the esophageal gastric junction, and a lot of times when we separate the GI organs, there's going to be a juncture, right? Small intestines go to your stomach goes into your duodenum. That's the first part of the small intestine. Then you go to the jejunum, the second part, and then you go to the ileum. Then you transition to the ascending colon, transverse colon, descending colon, sigmoid, etc. Every transition, there are differences in certain structures as well as tissues. And when you look at the anatomy, there are several ligaments that we're going to go over today. For a gastrointestinal surgeon, so in case one day you decide to finish up medical school and you want to specialize in gastrointestinal, GI, knowing some of those ligaments are important because it tells you what borders are located where. Okay, so if you're going through surgery, a surgeon will use those ligaments as a guide to know, okay, we've got to the point where this is the left lobe, this is the juncture between the duodenum and the jejunum, etc. Then we have one sphincter called the esophageal sphincter. This is what contracts, relaxes, and prevents any kind of gastric contents retracting back up. Very, very common, right? You hear about people having acid reflux disease, GERD, right? G-E-R-D. And that's not a good case, because when you have that acidic content from your stomach and you have the repulsion back up, you then most likely damage the tissue. And that chyme, or the acidic contents of your stomach, is a pH of what? Anybody have an idea of what kind of pH we're looking at for your stomach? Yeah, 1 to 2, right? It's more 2. So HCl, hydrochloric acid, gets secreted. The environment is pH of 2. That's very, very acidic. And as a result, that chyme, that milky white substance, could easily corrosively burn through your epithelial lining. That then leads to a condition called ulcers, right? You have bleeding, and oftentimes upper GI bleeding results in very, very dark colored stool when you go and use the restroom. Okay, so it's upper GI. On the right side, I just want to zoom into it. So right here, you can see this is a cross section where it's cut off the stomach, and then you can see there's a muscle. So the food tube, the esophagus, sits right behind the arch of the aorta, comes along, normally flat, comes down, and then passes through that muscle layer. And then there's quite a few blood vessels involved, which I'll list out in a second. But this opening right here, as it connects into your stomach, is called the esophageal the Z-line. Okay, the esophageal gastric juncture is called the Z-line. So Z-line in muscle is the border for the actin and myosin, right? Remember the sarcomere, but this Z-line is the demarcation between the esophagus and the stomach. All right, so then as far as the blood vessel goes, I'm trying to kind of focus it as easy as possible. So the arteries that supply the stomach is going to be from your left gastric artery, as well as your left inferior phrenic artery. So on the right, I have a little map showing you a small little highlight of that blood vessel. So right here on the right, you can see the esophageal branch of the phrenic artery, tiny little branch right here, and then the left gastric. So these are the two dominant main branches that provides most of the blood flow. Some of the smaller ones you see over here, the esophageal arteries, these tiny ones are sub-branches. Whenever we go into the small, tiny branches like the anatomoses, don't worry about it. It gets too tricky. So there's always going to be a dominant one, and then the immediate branching. When you go into the GI, right, you have your abdominal aorta. That's the main tube. The first branch is your celiac trunk. We're going to talk about that in a second. That goes to your stomach. Then it branches to your superior mesenteric, inferior mesenteric, and then renal. Right? So just remember, abdominal aorta is the big highway. That's the main. Think of it like the 405 in LA or the 5-lane highway. If you've ever seen a freeway that's like 4 or 5 lanes, that's the main one. And then it deviates off to the smaller freeways that have 2 or 3 lanes. Okay, so in your mind, abdominal aorta, then we have the celiac, superior mesenteric, inferior mesenteric, and the renal. And I'll have some pictures, but just keep those terms in the back of your mind. As far as the venous and lymphatic drainage goes, very nicely, it mirrors. So we have the left gastric vein, and as far as the lymph nodes, the dominant section is the celiac lymph nodes. So you're going to hear a lot of terms celiac, mesenteric, inferior mesenteric. These are all GI related. Right? They just tell you the location. Celiac is a little higher. So celiac, think stomach. Inferior mesenteric, think of the lower GI, your descending colon, your sigmoid colon, and then superior mesenteric, think of your small intestine. Think of it as 3 sections of your GI. Or if you remember in the first week of this course, right, we're backtracked to August, September, we have the upper left quadrant, upper right quadrant, lower right, lower left. What organ will be behind the upper left? Any guesses? So upper left, if somebody was palpitating around your upper left or you had pain, patient comes in or somebody comes into the ER and they're like, I have upper pain, upper left quadrant pain. What organs are we referring to in this area? The gallbladder's on the right, right? Upper right, that's gallbladder. Stomach will be a little further up. It's actually deeper within. This part is usually more the second part of your small intestine in your spleen. Okay? So in terms of location-wise, and that's also why whenever you go in for a checkup, or whenever you go into a GI doctor's office, and you're trying to get an assessment, they will always ask you to take a deep breath. So when you take a deep breath, what happens to your diaphragm? Contracts, it squeezes, and so when he squeezes, the organs are able to expand out, and then you can then feel them a little better. Okay, so those are some of the significance there. As far as the innervation goes, the main one is the vagal trunk. So most of your GI system is under the control of the vagus, right? And what does it do? Under the parasympathetic division of the autonomic system, does it favor peristalsis? Does it favor the movement, motility of the food, or does it not favor it? Favors it, right? So when your body is in that parasympathetic state, the SLUD, the calm, the resting, then your body is able to squeeze. Most of the GI will be dilated, so it allows the movement of food and maximal absorption and dilation of blood vessels. Okay, good. All right, and then over here, we're going to transition quickly to the stomach. The second organ here listed is your stomach, and then on the upper part, you'll see there are quite a few structures. I listed the main couple items I want you to be able to identify. So this is a real kind of core to anatomy, making sure you know each of the functions of all of these structures. The first one is the cardia of the stomach. The cardia is the upper entering tube that leads into the pouch. All right, so if you look at the picture on the right, I know it's a little, I'll have the cadaver images today and we'll do the HoloLens, those are better, but you'll see right, this is the entrance into the upper part of your stomach, and that part is called the cardia. The fundus is the upper left, or on this picture, upper right, but your upper left region, and this is what stores the food. Okay, the fundus is what houses the undigested chyme or the bolus, and eventually as the parietal cells do their job and as the acid gets secreted in and histamine comes along and then conversion of protons to HCl occurs and then also the activation of trypsinogen, then you have this milky white corrosive acidic chyme. Okay, they call it chyme. CHYME, and this chyme is that toxic, very corrosive stuff that you're trying to neutralize. What would happen if you didn't neutralize this chyme and it goes into your small intestines right here? What would likely happen if you're constantly exposing the chyme to other parts of your GI organs? Ulcers, right? You can have peptic ulcers, that's in your stomach. You can even perforate the stomach lining, right? So if you have some kind of bacteria, but if you constantly have ulcers, that's usually what they believe that leads into esophageal or some kind of small cancers, is that you're having this constant damage of the mucosal lining of the tube. And as a result of that constant damage, it teases off, it regenerates, it heals, and you damage it again. And over the years of doing that, there's a higher chance of cancerous growth. So having acid reflux or having that chyme not regulated is horrible, right? And that relates to what kind of diet and some kind of foods that you tend to eat. Then we have the body. The body is the major part of the stomach. So you can see right here on the right side, the pink area, this entire part is the body. Usually when you hear about bariatric surgeries, everybody heard of the bariatric surgery? So when you're having weight loss issues and you lose some weight, or the best show is that 600-pound weight life, where you have a lot of folks that are extreme BMIs and extreme obesity, asking for bariatric surgery. What they do is they'll usually staple or remove a section of the fundus, also the part of the body. And what happens here, and this is the downside of that, is that when you do have those bariatric surgeries, and again, I believe there's a time for it, right? If you're extremely overweight and you are trying to limit how much food the stomach can actually house in, the capacity of the food that goes in, then it makes sense. But the endocrine cells, and we'll talk about the cells in a second, but the cell types that regulate GLP, satiety, the hormones, acetylcholine, the histamine, all those cells, once you cut it off, they're gone, right? And so the receptors that regulate your natural GI's rhythm and your satiety, how full you feel, and how your body reacts to food, those are all gone. So the downside to bariatric surgery, in my opinion, is that the endocrine side is completely lost. You can't revert that. You can't just regenerate those cells, right? It's gone. It's physically gone. Then we have the pyloric part. Pyloric part is going to be the distal funnel shape. So right here, you can see shown in blue. It's actually nice and color-coded, so you can see it. That blue area, the juncture between the stomach to your small intestine, will be pyloric part. And then you'll see there are two curvatures. The lesser curvature is the one on top right here, the superior curvature, and the greater curvature is the one that sits on the bottom. Obviously, as the stomach distends and as food fills in, it stretches. If you look into it, and I have a nice image in the cadaver, is there are series of what they call rugae, okay, rugae or ruga. These are the gastric folds. You can see they're all like kind of like a plastic bag. They can coil together. And if you're eating a lot of food, you can distend the stomach to expand. And maximizes the ability to stretch. It increases the ability to then fill food into some contents, right? So you can see right here, this is a pretty cool picture. The folds right there, and then they can expand out. And then the last one here is that within those mucosal layer, you're going to have some of the gastric pits, and that's where all the HCl conversion occurs. I'll talk about that mnemonic on the board here. So this is a mnemonic that I'll share that kind of snapshots all the key cell types in one area, and I'll have a couple of visuals too, but you should be mindful of the cells and what they secrete, okay? Because we're going to get closer to endocrine, and the study of endocrines is knowing what kind of cells are available and what kind of hormones they release. All right, so this is a list of key structures. Anything in highlight, guys, I try to make it a little bit more narrowed for each slide, is that whenever you go through the slides, all the highlighted stuff, just pay a little bit more attention to, okay? And then over here, as far as the arterial supply goes, they come from the celiac trunk, but there's three specific branches that I want to highlight. The left gastric, the common hepatic, and then the gastroduodenal artery. Those are the three major arteries that supply to your stomach. And on the right, I highlighted for you, so you can see right on the left side of this, left side of your body, or right side of the image, is your spleen. The splenic artery passes posteriorly through the stomach and then hits the spleen. And over here in the celiac trunk, oh, good morning, guys. Welcome. And then we have the gastric gastric artery up here, and then we have the common hepatic artery and gastroduodenal. Okay, so those are the main ones. Don't worry about some of the tiny ones. When you see these images, they're giving you other arteries as well. So for example, the cystic artery right here, this is what's going to branch towards behind the liver for the gallbladder, right? There's a lot going on. Your GI, there's a lot going on. So when you look at the pictures, try not to be overwhelmed with all the different arteries and just focus on the 2 or 3 that the slide is pointing to. Okay? All right, so recap real quick is the left gastric artery. Hence, for your vein, you have the left gastric vein. We have the portal vein and the splenic vein, which are the main drainage sites. And then we have the common hepatic and then the gastroduodenal. Okay? Whenever you see the word gas, just remember it's related to your stomach. Duodenal, that's your first part of your small intestine. Duodenum. Within the duodenum, which I'll show you today, is there are 4 parts. So out of all the GI organs, your stomach, small intestine, your colon, sigmoid colon, rectum, the one that has the most amount of subdivisions is your small intestine. Okay, we'll go over that. So there's duodenum, first section, jejunum, middle section, ileum, third section. But within the duodenum, there are 4 subdivisions. Okay, so really it's almost like 6 subsections in that region. As far as innervation goes, just like we said before, it's parasympathetic division, and most of that innervation comes from a vagal tone. Sympathetic is going to sub-branch from the T6 to T9, and this is the exact opposite, right? So when the sympathetic activates, bless you, what happens when the sympathetic activates? It's going to do what? Reduce motility, right? Slow down the movement. There are 2 movements that we're going to talk about. When we go into this topic, I want you to be aware of the 2 words. The first term is called peristalsis. What does that mean, peristalsis? Okay, smooth muscle. It's an autorhythmic squeezing motion where you're propelling the food in a squeezing motion, right? Then what's segmentation? Good. So the smooth muscle is actually kind of chewing, right? Kind of mixing and chewing and really cutting into the bolus. So you're mixing the stuff. So those are 2 motions. When we talk about the GI motion, you're going to hear about peristaltic motions and segmentation. And when you have irregular issues, and I'll maybe engage you a little bit if you want to see a couple of diseases. The one I presented for the Monday session at the medical school. Like for example, there's a condition called Hirschsprung disease. Hirschsprung disease is when the colon, the smooth muscle in the colon, is in a constant spasm state. So you can imagine that your colon, right, your big large intestine, it's a big tube. And normally when you're getting good bowel movement and you're eating the right appropriate foods, it moves along and you don't have constipation. It goes out whenever you need to use the restroom, right? Nice and smooth. But if you have Hirschsprung, certain areas of the colon are literally in a spasm state, so it can't contract. So the waste builds up in your colon. And one of the symptoms that you hear always about in GI issues is constipation, right? So again, as you're going through this topic, one of those symptoms that relate to majority of conditions is either some kind of change in stool, liquid stool, constipation, reduced frequency of fecal matter discharge, or maybe even blood discharge in the stool, right? So those are some of the indicators of, hey, maybe there's an issue, or maybe the bowel movement is not present, and then there's a change in terms of what kind of food or what kind of smooth muscle activity is going on. As far as the stomach goes, there are some structures that relate to the greater lower GI. So on the right side, you'll see that the stomach fits right here, and then on the right side, we have the liver, the gallbladder is behind it. And then there are 2 omentums. These omentums provide a kind of a stability. It also is like an apron that sits over and cushions the stomach. The lesser omentum is going to be the one up here on top, and then the greater omentum is the one below it. Okay, so this is an apron that kind of maintains the curvature, attaches to the greater curvature on the bottom side. Most of the time when we talk about GI organs, I want you to think about the term retroperitoneal, and then the other term is called intraperitoneal. I'll put this on the board in a second. I'll list it all out. But what does intraperitoneal mean? Well, what's peritoneum? What's a peritoneum? This is a word that we went over maybe the first couple of weeks of school. Peritoneum. Anybody remember? Peritoneum. Is it lining? Exactly, right? It's a coating over in your GI. So certain organs are cushioned maintain depending on the cavity, right? Because you have your anterior cavity, you also have your posterior cavity. So certain organs in your GI are anchored towards the front cavity. Those are usually going to be intraperitoneal. Those ones also will have a mesentery, a layer of membrane that soaks around it that provides a little bit of wiggle room, a little bit of movement. What is retroperitoneal? That's going to be the ones on the back, okay? So they're adhered to the posterior cavity. Generally, they're not going to have an omentum. Anybody have an idea of what organs are retroperitoneal? Kidneys, really good. What else? Okay, well, that's part of the kidney. That's good. Yeah, really good. Yep. So kidneys, right? Ureters, female ovaries, the ascending colon, descending colon, certain sections of the GI is retroperitoneal. Certain parts of your small intestine are also retroperitoneal. And then you also have the other section, like stomach, other half parts of the pancreas are intraperitoneal. So that's why if you were to go in invasively to your GI cavity, certain organs are further back in, and some other ones are more anterior. Okay? All right, so then over here we have the anterior attachment for the stomach. I want to make sure you're aware that on the anterior attachment, we do have the diaphragm that attaches to it. We'll go over the lobes in a second of the liver, and then on the posterior side, we have the pancreas, right? So this is why you really can't see it well unless you tease off the apron of the greater omentum. So you would strip this all layer off, and then once you cut that all off, then you can see the curvature of the pancreas and where it sits. Your pancreas also has subsections. Okay, we'll go over the different areas as well. Basically, every GI organ almost have subdivisions because some parts of those organs could be retroperitoneal and other parts could be intra. Let me give you one tricky one. In the pancreas, only the tail is going to be intraperitoneal. The head, the neck, the body is retroperitoneal. So if you look at the pancreas, it literally is attached to the back and curves to the front. Okay. All right, so let's keep going. Over here, we have then one clinical application. And this is interesting to know that depending on your body type and a patient's physique, the stomach positioning could be slightly different. Okay. The term we use to describe the positioning or the body type is what they call hypersthenic versus asthenic. So hypersthenic means they're slightly bigger build, maybe a little bit bigger GI cavity, a little bit more overweight, and then asthenic is more slender, more narrow. And what do you see over here on the right? If you're hypersthenic, where does the stomach go? Is it pushed superior or dropped more inferiorly? Superiorly, okay? So this is important to know. So when you see an individual that has a more hypersthenic abdominal cavity or body type or figure, that stomach tends to be up elevated a little higher. If you are asthenic or more narrow, the stomach drops down further. Okay, so these are important to know because when you see a patient with a different body type, when you're auscultating or when you're trying to percuss to hear the sounds of the GI or doing a quick physical checkup, you know where you're placing your fingers or where you're touching. Okay? Yeah, Jason? You know, it's so I would probably say that the only issue is sometimes when there are infections, or let's say you would have a rebound tenderness or some kind of diverticulitis or appendicitis, any kind of injury, inflammation, that way you can localize the pain. But otherwise, it's just because there's a little bit more fat tissue, more adipose. Certain organs are also enlarged, right? So when you gain weight, or let's say you overeat and you have a greater obesity, you don't get to choose which organs enlarge. And one of the issues is that liver, hepatomegaly, and some enlargement of the liver can also occur. That can shift the other organs around. All right, so that is one clinical application. So let's go on. So then in the stomach, there are several phases in terms of how the stomach works. And I threw this slide in there just to give you a little bit of that connection with the physiology. I think is important. The main function, obviously, is storage of food in your upper stomach. The lower regions play a role for digestion. And this is where a majority of protein and lipids begin breakdown. Technically, right, carbohydrates break down in the mouth. You have the salivary amylase. There's also that lingual lipase. So some of the newer research shows that fat also breaks down in your mouth. But protein breakdown is your stomach. And that's where you have the HCl. And the famous enzyme that I will defer to the board there is called pepsinogen. If you haven't heard of that enzyme, I'm sure you'll hear about it in physiology. But pepsinogen is the inactivated form of the low kind of acidic environment stomach specific enzyme. The activated form is called what? Pepsin. Really good. Okay. And pepsin, and as you can see, chief cells, which is one dominant cell in your stomach, is what activates the denaturing of proteins, starts the breakdown of the chains between peptide bonds. And then it also plays a role for defense against pathogens. But on the right, you'll see that the way your body stimulates the stomach's churning in this gastric phase is literally from the thought of food and the smell of food. Okay, so if you're hungry, that's why when you're trying to study and you're maybe on Ramadan, anybody fasting? Nobody fasting? Okay, so if you're fasting, you'll know that this past couple of weeks has been really, really tough for some of the students at the medical school because we have a lot of students that do observe Ramadan. And you're fasting for 12 hours, and you come into class, you have to go through all this content, you take a quiz, take an exam, and you're hungry. Or you smell some food that somebody else is eating, that triggers your brain to activate through the medulla oblongata, which we've talked about many times already. The parasympathetic system through the vagal nerve sends a signal, and this long vagal reflex will stimulate the lower GI through its own autonomic ganglia called the enteric nervous system. Okay? What's fascinating about your GI system is that it has technically its own nervous system. It does get connection between your CNS. However, the autorhythmic motion is self-regulating. And within this enteric nervous system, what happens is whenever there is stretch, whenever there is protein detection in your stomach, it triggers the gastric phase. So one of the best ways to appetize or to get your stomach going is to eat protein. If you're having a good meal or you're getting ready to do a mukbang or a food challenge, get a little bit of protein in there to kind of get things going, right? Obviously, if you're a competitive eater, what do? They like drink gallons of water to expand the stomach. But most of the time, if you get a little bit of protein in your stomach, it gets the churning going, and so the gastric phase starts, increases motility right here, and so that helps the movement begin. Okay, so pro tip in case anybody's trying to do a food challenge, definitely a little bit of protein to trigger everything going. That might help. Over here, this is a very key slide. I'll put a little star to this one. This is all the key cells of the stomach, and I want to use the mnemonic. So this is the mnemonic I will share for this topic. The mnemonic I have on the board is chef's guest arrives at 8 p.m. Okay, so if you've never had to memorize these cell types, I think that'll be really, really easy to help snap it all together. C from the letter chef stands for chief cells. The guest starts with the letter G. That stands for G cells. And then arrives at, those are irrelevant. And then 8 with the EIGHT, the 8 stands for interchromatin cells. And then the PM is just the nighttime, right? So P stands for parietal cells. M stands for mucus cells. And that literally covers all the cells on the board. Okay, so you can use the board if you like. If you use the PowerPoint, just highlighting G cells secrete gastrin. This is one of the hormones that favors gastric release. Gastrin has the word gas in there. Its main function is to start to break down fats, okay, fats and proteins. The stimulus and the trigger for gastrin is what? What causes your body to make gastrin? Food, yeah, we just talked about it. Food, protein in your stomach, stretching stomach. What else? Which neurotransmitter do you think would favor digestion? Think about parasympathetic. Exactly, acetylcholine. Okay, so think about parasympathetic. Remember, we went over this a couple weeks ago where we talked about parasympathetic has acetylcholine, right, within the preganglion and the postganglion. And then sympathetic, we use mostly adrenaline or adrenaline. So acetylcholine is a chemical that favors the activation of G cells. G cells will favor the release of gastrin, and gastrin favors the release of acid. So it's a domino effect, okay? And then the second cell over here is the parietal cell. Parietal cells actually do two things. They secrete HCl by pumping the protons in. That's going to be for physiology. You'll see the cell type and the movement of chloride. And this is exactly the cells that you want to target, the proton pumps, to reduce acidity. So whenever you hear acid reflux and so you eat a lot of food at one time, you get like a pepsin or pepsid, one of those proton pump inhibitors to reduce acidity. It also makes something called IF, intrinsic factor. Anybody heard of this before? What does that do? Intrinsic factor. Really good, yeah. So intrinsic factor is a protein which will help bind onto vitamin B12. And as it goes through your stomach and your small intestine, it preserves its integrity. So the later part, so the third part of the small intestine, the ileum, can actually absorb it. Okay, so the part of the small intestine, which we'll talk about, that absorbs the B12 is called the ileum. Okay, it's the third part of your small intestine that's dedicated to have receptors to bind IF. So that protein is a hitchhiker for the vitamin B12. Right, really good. And then, of course, we have the chief cells. The main function of chief cells is to produce the pepsinogen, and the active version is called pepsin. How does it get activated? Anybody? How does pepsinogen turn into pepsin? What's the trigger? Low pH, pH of 2. Okay, so pH of 2 activates the enzyme. And then we also have some gastric lipase, so the breakdown of lipids here. And then we also have the ECL cells. So on the chart on the board here, I wrote on the bottom left, interchromatin cells, and I have the compound or the signal molecule histamine in there. So histamine is that general compound that favors gastric acid secretion. It favors acetylcholine. When you think about all of these hormones and signals, the easiest way to divide it is which ones favor acid and which ones don't favor acid. Okay? Everything in your stomach is going to be acetylcholine, histamine, gastrin, pepsin, favors acidity and favors the breakdown of the food product. When it goes from the stomach to your small intestine, what do you think has to happen? It needs to do what? Neutralize the acid, right? So you're going to have bicarbonate. We'll talk a little bit about CCK and secretin. That's a counterpart. Those are the two hormones that favor the secretion of the bile. The bile contains some of those lipase and the alkalinic juices to favor the neutralization of the acid. Okay, so it's just really two sides. We have the acid stuff, and then we have the basic stuff, and they have to kind of balance out. If one overtakes the other, then there's going to be issues. And then we also have some subcells in here that is not on the mnemonic. So the D cells do secrete a hormone called somatostatin. I won't talk too much about this except for the fact that this is the counter to growth hormone. Okay, so it's one of those hormones that inhibits the growth hormone feedback in the body. And this one does inhibit gastric. Okay, so I want to put a little note to D cells. These cells are found within the pits of the gastric glands, a little bit lower in the glands, and their function is to slow down the acidity. We also have G cells, like we said before, also in the pits. This is where the gastrin. And I like this image here. This is actually pretty nice because it does show you the relative location. This cartoon image is a snapshot of a pit. I'll have a couple of histological images to show you, but you can see that the distribution of the cells are not even. Everybody see that? On the upper parts, you have the mucosa cell. In the neck region, you're going to start to have some of the parietal cells. Interchromatin cells are right in the kind of the midpoint right here, right in the middle. And the D cells and G cells are at the base. Okay, so when you do look at a gastric gland or gastric pit cell, you use the location or region to be able to snapshot what cell type it is. Because if you just look at a cell, it's almost impossible to decipher, right? Because it's just one nucleus, one cell membrane. They all look a little cuboidal. You can't really tell from that. All right. So this is an important slide. Be mindful of this. Okay, and then over here, I'm not going to go into the weeds here, but I just want to show you that when you hear about folks eating Pepsid, so if you had bad acid reflux or if you've ever felt that before, whether for me the trigger is when I eat too quickly sometimes, or sometimes if I eat too much fried or fatty foods, that can trigger acid reflux. But right here inside the stomach, you have this one kind of cell called the parietal cell. On the parietal cell, we have a couple of pumps. We have a bicarbonate chloride pump. These ones are going to be antiporters because they're both negative charge. Chloride goes into the cell as bicarbonate goes out. So what happens is it makes the inside of your lumen of the stomach more acidic. When the chloride comes in, it's going to go through a chloride channel, and now you have the chloride, right? And over here, you can see there's a potassium proton ATPase. Then the proton goes in for an exchanger for potassium. And now when you have the proton with the HCl, with the chloride, you make HCl. Okay, so that's how you build up the acidity inside your stomach. When you hear about those proton pump inhibitors, PPIs, those are really, really useful because they bind to that proton pump, ATPase, to block it, so it reduces acidity. Okay? And there's also maybe a not indirect way, but I can probably share a pretty cool little hack, is that because of the way your stomach acid activates, the histamine is so powerful and dominant. In some cases, when you're drinking alcohol, you probably have seen folks that have that red tint, the flush, the Asian flush that you get. One way to not get the redness is to take a PPI. So you reduce the histamine, and overall the immune system will be suppressed to some degree, so you have less of an allergic reaction. So some folks, when they don't want to look like they drink, you want to look like you didn't drink alcohol. You might still smell like alcohol, but your face doesn't have that glow. You take a PPI before you take alcohol. All right, then over here, let's talk a little bit about, the peristalsis. So the intestinal phase then is after the food has gone through the stomach and after the acid has mixed with the chyme, and now there's corrosive, milky white substance that's getting ready to enter your small intestine. So this peristaltic motion has to be regulated because you don't want to dump all the stomach contents in at once. So there's a churning motion that occurs. And now as you go into the intestine, the goal here is for maximal absorption. So we'll go into the anatomy first, and then I can revisit this slide, but let's talk a little bit about your small intestine. So your small intestine contains 3 sections: the duodenum, the jejunum, and the ileum. On the right side of this picture, can you guys see that there are actually 4 parts to the duodenum? Part 1, part 2, part 3 is inferior, and then part 4 is ascending back up. So within the first section itself, there are 4 subdivisions, okay? Superior, descending, inferior, ascending. Usually I like to refer to them as 1, 2, 3, 4. So part 1, part 2, part 3, part 4. What's significant here is each part has a slightly different feature, okay? Within part 1, I know this is not the best image. Within part 1, you have the ampulla that provides the opening for all the pancreatic juices. So there's something called the ampulla levator, or the duodenal papilla. This little opening where the juices come in. So it comes in right here. So imagine your pancreas, right? This is your pancreas. You have the pancreatic duct. Let me use another color. So imagine you have this pancreatic duct shown here in green coming along. And then from the bile, or from the gallbladder, you're going to have the bile duct that comes down from the top, okay, the orange. And then they're going to join together with the green and orange together to open into the little duodenal papillae right here in part 1, where the juices come out. So the reason why part 1 is significant for the entering of the juices. Okay, part 2 is going to have the curvature right here, and this is the region where you start to ascend down. Part 3, you also, by the way, between part 1 and 2, right behind it, and this is not the best image, but if you were to flip this image around, behind part 1 and 2, there's a ligament. A ligament shown in the black line, that's called the hepatoduodenal ligament. That maintains the structure and then the location of it so that it's right next to the pancreas. When you're going through surgery or if somebody's going invasively, it's a way to be able to access what's around it. So there is a ligament right there. And then when you go down to 3 and 4, there's also going to be some changes of blood flow. But in part 4 right here, there's another key ligament called the ligament of Treitz. I have this in the next slide. The ligament of Treitz. And this is one of the most important, I would say, boundaries for a surgeon. When you go in and you're cutting in, when you see that ligament, you know you're at the border between the duodenum and the jejunum. It literally is like a little bisecting line. So when you're cutting in, and then you're a surgeon in training, you look for that ligament, so you know this is the left side of that will be the duodenum, the right side of that will be the jejunum. Okay. All right. So let's keep going. Do a few more slides here, and then over here we have the 4 parts. So superior is E, corresponding over here E, and then the descending is the C part, and then the D is the inferior or the horizontal. Horizontal is a term that I listed because some books do use that. Most of the time I just use inferior. So if you ever see a question when they say horizontal part or the inferior part, that's the same thing. Okay, so this term is the same as inferior. All right, but here are some of the key structures that I want to highlight. So within the superior, you're going to have the duodenal papillae or the duodenal cap. Within the descending part, you're going to have the head of the pancreas. In the inferior part, this is where you have the passage of the inferior vena cava and the aorta. And then the ascending part is you have that, again, the ligament of Treitz, which is basically your duodenal jejunal junction. So it's transition between the first part of your small intestine and the mid part. Okay, different cell types, different functions, right? Then they're going to have more absorption base. Earlier, I said that the intrinsic factor and B12 is absorbed where? What part? Which section of the small intestine does the intrinsic factor and B12 get absorbed? That's important to know. Ileum, that's the third part. Okay, the last part. All right, so not the duodenum, not the jejunum, it's the ileum. Okay, good. All right, nice. Good. Okay, so over here, zooming into this, in the first part, just highlighting, making sure you know the ampulla or the duodenal cap. We also have the hepatoduodenal ligament. This is the one that adheres to the lesser omentum. And then what I also wanted to highlight, and this slide in particular is one I used from the medical school. So this one came from medical school. I added this one in a little bit more detailed. This one is significant because the superior part, or the first part, is the only part that is intraperitoneal. And it doesn't have a mesentery. So it's slightly more mobile. And then all the other three, right, the part 2, part 3, part 4, they're all retroperitoneal. So one important location in terms of anatomy is that the first part of the duodenum is intra, so it attaches to the front. Parts 2, 3, and 4 attach to the back. Okay, so that's how it stays in place. Right? Obviously, if you haven't seen it, like if you dissected a cat or maybe seen a cadaver before, or maybe a fetal pig, when you open it up, you'll realize the positioning of your small intestine. It's not just gooped right in the middle, right? There's a place where it binds to so that it can maximize the movement. Okay. I have the cadaver images, so I'll show you that. Just keep that in mind for now, right? So the first part is interior, intraperitoneal, and then parts 2, 3, and 4 are retroperitoneal. Then we have part 3. This is going to be right at the L3 vertebra, and then highlighting the key structures that passes over the IVC. It also passes over the aorta, and then the L3. New, is that door open? You can just prop it open. Yeah, that's fine. Because if you guys want to walk in and out, it's all good. And then part 4, guys, is going to be right at the end of L3 to the L2 region, and it contains your duodenal jejunal flexure. And highlighting, guys, right here is the ligament of Treitz. Okay, so ligament of Treitz is literally the bisecting ligament that holds the two places together. And you'll also see a little bit of the diaphragm, so a little bit of muscle as well in that area. We left off on the duodenum, and I said that there are 4 parts, right? 4 parts to the duodenum. The third part is right at the L3 vertebrae, which passes over your IVC aorta. It also includes parts of the superior head of pancreas. The pancreas is a small leaf-like gland, right? Nothing impressive, but if you go into it, you'll see that there are a head section, a neck, a body, and a tail. And it spans a good amount of length. And so the head and the body and the neck, those are all going to be considered retroperitoneal. The tail, though, bends anteriorly, which is intraperitoneal. Then over here, we're going to go on from the duodenum to the jejunum and the ileum. As far as characteristic goes, I want to give you a quick snapshot of the key differences, because when you think about it, they're all the small intestine. It's hard to distinguish, and in a cadaver, they're never color-coded, right? So you just see this long tube that coils within your abdominal pelvic cavity. The LUQ, so your left upper quadrant, is generally where the bulk of your jejunum sits. Okay, so whenever you're palpitating in the upper left, jejunum takes over a majority of the area. The right lower quadrant, lower right, is where the ileum is at. That's where the B12 intrinsic factor is absorbed. So again, just remember, left upper is jejunum, right lower is ileum. Okay, so that gives you positioning. As far as the characteristics goes, the wall of the jejunum is slightly thick and heavier. The ileum is a lot more thin and more narrow. Vasculature is also interesting to notice. There's a lot more blood vessels in the jejunum than there is in the ileum. There's also a little bit more fat mesentery, a coating layer inside the ileum. And then on the bottom here, I want to highlight this part. So what do you notice? What is the feature? So in case something is not clean, or you have bacteria pathogens potentially getting through your stomach that didn't get killed by acid, Your small intestine has to trigger the immune system. Your ileum plays a role for immune surveillance. So that is also why there's a lot more lymphatic nodules called the Peyer's patch. The Peyer's patch, I know this is on the bottom left, it's a little small. Peyer's patch are dedicated lymphatic nodules that are heavily condensed in the ileum that can trigger immunal activity. Okay, so so if you saw a cross section, if you took the small intestine and you cut it across, and you look into the tube, you will see little nodules that look like little tumor growths, but those are the Peyer's patch. Those trigger the increasing of neutrophil attacks. In some diseases, when you have an abundance of neutrophil attacks, then they swell up and they get bigger. Okay, so that is a quick snapshot of jejunum ileum. As far as the blood vessels goes, the key branch comes from the celiac trunk. So we have the gastroduodenal arteries. I'm not going to show you, the reason why I didn't have all this highlighted is because I actually have a chart that literally gives you the main origin and then the key branch and then what organ it supplies. All right, and I do this for the medical school because that one makes it a lot easier. But if you're somebody that really wants to get into it, on the right here you can see the gastroduodenal artery. They generally all either come from the celiac trunk, that's your stomach, or the superior mesenteric on the left, or the inferior mesenteric on the right. Those three are always going to be your main origins. Then, from those origins, you branch into the specific areas. For example, your jejunum ileum is supplied by a branch called the intestinal artery that comes off from the abdominal aorta. Your ascending colon that goes up, that's going to be your right colic artery. Transverse colon is going to be your middle colic. Left colic is descending, and then sigmoid. Okay. We also have the smaller, tiny ones like the appendicitis. The appendix, that's going to be the appendicular artery, so there's a whole branch. In some folks, though, going back to what we said many times, is that there is also going to be deviations in population. One of the kind of the traits I could probably say with confidence is that the mesentery, so in the large intestine, certain individuals, like 35%, 40% of the population will have a shorter mesentery. The remainder, 70%, has a longer apron that covers over the organ. So the distribution could be a little bit different, and some anatomy might have variations. The venous drainage will be the hepatic portal vein, also the inferior and superior mesenteric vein. And then the innervation is pretty straightforward, right? The vagal turn, so we have the parasympathetic innervation from the vagus nerve. And as far as the sympathetic division, we're going to have the celiac and superior mesenteric plexuses that control the rhythm. As far as the parasympathetic division goes, the vagal tone comes from the brain, right, the vagus nerve. But within the GI system, we have the enteric nervous system. That is also intertwined within the mucosal. So we have technically what they call the submucosal plexus. It's the set of neurons embedded inside the submucosal layer. Any takers on how many layers is in the GI system? So your whole food tube, your stomach, your small. How many layers is a tube? 4, right? What are the layers? So it's really good. So you have mucosa, inner lining, submucosa. That's where you have the lymphatics. That's also where you have the autonomic nervous system. Muscularis, and within the muscularis, we have smooth muscle. How many layers of muscle? 2. Okay, most of it has a circular muscle and a longitudinal muscle, but the stomach, which I didn't show you, has one additional transitional layer. So out of all the GI system, your stomach is the only one with a third layer of smooth muscle. It's a transitional, allowing the churning and the gastric mixture of the chyme. All right, are we good? So those are some of the key traits for the smooth muscle in the tube. Over here, I wanted to highlight that in the intestinal phase, the ileum is where majority of that vitamin B12 and nutrition factor gets reabsorbed. We're not going to go over all the different macros and where they get broken down, but most of the time, right, your fats, your proteins, your carbohydrates are all going to be absorbed in your small intestine. But I did want to highlight that oftentimes minerals and vitamins are absorbed along with other kinds of fats. So right here, fat-soluble vitamins are usually transported together with fat-based compounds. Vitamin B12 is a unique one. This one and intrinsic factor, they're both absorbed within the ileum. Okay, so that is something that will be helpful for you to know. When you have a deficiency in the ability to get B12 into your body, it results in anemia. the subclass of anemia is called pernicious anemia. That's where the nucleus gets fragmented, and oftentimes it could be because of either the intrinsic factor being not present or the B12 not available. Okay. Then the iron and calcium also gets heavily regulated over here. So the ferritin binding protein to the iron is transported, and this is also where most of it gets absorbed. Just to zoom into a little bit, just a tiny little bit of physiology, I just wanted to highlight that there are three kind of cells, or sorry, three kind of transporters. So on the first image here, we're going to have the iron transporter. Iron transporters with protons. This is called a DMT1 transporter. That moves the iron in, and then the Fe goes from the lumen to the ECF. So there's where you can regulate how much iron is taken in. In the middle picture, we have the calcium absorption. Some calcium gets to go through the cell in what we call paracellular transport. So that means it's not through the cell. If it goes through the cell, we call that transcellular. Right? That goes through a door, and then goes into the cell, and goes through another door. And in that case, we have a dedicated calcium channel. And over here, and you're probably aware that almost everything goes with sodium, right? So whenever you want absorption of any kind of macros, sodium is the default ion that transports with it. So we have a sodium-calcium antiport. On the far right, we have a picture showing you the chloride absorption, potassium, and sodium, okay? And then we have the famous NAK pump. NAK always goes in opposite directions. Whenever potassium goes into the lumen, the sodium goes into the ECF. And just be mindful, right? So whenever we think about small intestine, think about your minerals, your sodium, potassium, calcium, and of course we said the B12. So some of the enzymes that are present are also very, very important, okay? And you're probably going to get a little bit more of this in the physiology course, but the two broad classes of enzymes include what? What macros do we have to break down? Protein, right? And then we get smaller, we have the specific amino acids, right? We got to break them down to the amine group and then the carboxylic acid group. For sugars, we have different kinds of sugars, right? We have what? Glucose, fructose, galactose, sucrose, maltose, the disaccharides, the monosaccharides, or the single sugars, and the two sugars. And then, of course, we're going to have also nucleosidases, the one that break down DNA, but we're not going to go into those. We have a family called the endopeptidases. These are a family of proteins that break down the protein. And we also have the exopeptidases. The difference here, or some of the subclasses that you're going to hear about, include the zymogens. Zymogens are the inactivated form. The first one I said is called pepsin. Okay? In case you didn't hear and you went out for break, on the mnemonic that I have, the chief guest arrives at 8 p.m. The chief likes, or the chef, or chief, whichever word you want to use, the chef likes to drink Pepsi. So chefs like Pepsi. Pepsi sounds like it's pepsinogen. And then the 8 at the end of the phrase stands for the interchromatin cells. And I just have a little rhyme that history is entertaining because history, H-I, the first two letters of history, is histamine, is entertaining. Entertaining sounds like interchromatin, so it's related. And then the last one, H-I parietal, high parietal cells. H stands for hydrochloric acid, and the I stands for intrinsic factor. Okay, so that way you know which cells go to which ones. You probably guess already that in today's questions that I will do, and you probably see it on the final exam. You'll have some questions on, hey, maybe a patient comes in to the hospital and there's a dysfunction or dysregulation of a cell type in the body, in your stomach, causing an overproduction of acid. What could be the cause? Right? Or which one could be the issue? So that's a tricky one because when you think about it, there's a cascade, right? The histamine triggers, acetylcholine triggers the histamine. Histamine triggers the G cells, makes it more acid. Gastrin makes more acid as well. So sometimes it could be tricky to isolate just one cell or what might be the direct cause. And then we also have another one called the trypsin and chymotrypsin. These are the ones made by the pancreas. They also break down proteins. And then we also have the exopeptidases, which are the ones that break down the specific amino acid. So we said earlier, the amine group and the carboxylic acid group. So we have the aminopeptidase and carboxypeptidase. Okay, so just be mindful of the enzymes. Don't worry too much about the images. It's just for you to look at. And this is where most of the amino acid gets absorbed. Right, so at this point, most of your protein is now single amino acid. It shuffles with the sodium and goes right in. And I think I have one for the carbohydrates. Yep. So this one is going to be a snapshot for the carbs and the fat. In order for fat to be broken down, what do we need? Can fat just get processed by any of these enzymes? What is required? What's that concoction that your gallbladder secretes? Bile, right? And what's in bile? What is bile? Now you hear about this. This is the kind of green, juicy stuff. What is bile? What's in there? So it's a mixture of lipases, some colipase. You have bicarbonate, alkalinic fluid. It's really a mixture of juices. Within that mixture, you have two enzymes I want to highlight. One called lipase, one called colipase. The lipase directly breaks down the lipid bonds right within the triglycerides, and then the colipase is one that assists with the transportation. So they work together, and then this is how then you get the bigger fat molecules to be emulsified to a smaller single micelle, and then you can transport it around. The term chylomicron, this is a fat transport boat that allows you to shuffle the lipids from the cell to the outer sides. And then on the bottom here, I also wanted to give a little shout out to the carbohydrates. Okay, so different kinds of carbs that broken down, but the first enzyme that you have to know is called amylase. Amylase breaks down what kind of sugars? Is it polysaccharides, disaccharides, or monosaccharides? Anybody? Anybody? Which ones? Amylase. No, it's poly. Okay, so the moment you eat something, right, you don't know what kind of sugars you have, what kind of carbs. It breaks down the big chained sugars, salivary amylase. That's called the alpha salivary amylase. That's the first version. The second version is called the pancreatic amylase. Same thing, but made of different kind of organs, okay, or structures. And then over here on the bottom, what I highlighted is I highlighted three specific doors or three specific transporters. I think these are pretty important, okay? This will overlap with physiology as well as overlap in medical school. The SGLT. SGLT stands for sodium glucose transporters. Their job is to move glucose and galactose into the cell. All right? SGLT, just remember, glucose and galactose, milk sugar and normal glucose, those go together. Fructose, right? Some of us like fruits. I love fruits as well. So fruits also has a lot of carbs and sugars. They go through GLUT5s. So it's a different channel. That's also why some folks maybe prefer to have a little bit more of a fruit sugar than just having maybe like a straight sugar for dessert. And then we also have the GLUT2s, which is going to be the exit channel for those sugars into the lumen. Okay, so if you look at the picture, on the lumen of intestine, when you absorb the nutrients, you have either the SGLT or the GLUT5. Then the exit channel over here on the bottom is the GLUT2. So in order for the macro to go in the cell, it has to go through a door, enter a door, and then exits a door. All right, so just keep that in your mind, and then these are all within the small intestine. Now the final section here, as we go through, is going to be your large intestine. We'll talk a little bit about the ascending colon as you go up, transverse across, descend down. We're going to make a U-turn called sigmoid colon, go through the rectum, and go down the anal canal. Next week, I'll focus on the anal canal. So for today, let's go ahead and skip the anal canal a little bit. We'll just talk a little bit about the general histology, cell types. Over here, when you look into your large intestine, one of the biggest differences is that there's a band, a very long band, if you look at the picture, that stabilizes this into like a frame structure. It literally frames over your small intestine. These little lines you see in the middle, so let me use another color. The little lines in the middle of the colon, this series of lines is called the tena coli. This is a band of smooth muscle that maintains the upright integrity of the colon, okay? Around the colon, what do you guys notice the visual? How does this tube look like? It looks really what? Kind of lumpy, right? These little pouches, you guys see that? There's a lot of these lumps right here. They kind of lump around the whole tube. These lumps are called the haustras. Okay? Has anybody heard of a disease or a condition called diverticulitis? Or IBD, irritable bowel disease, Crohn's disease, ulcerative colitis? Those are all under that category. When there's dysregulation, or if the pouches of these haustras get thinned out, or when they get expanded to the point where they can burst, that causes pain. And the haustras, or these pouching, are what enable the nice rhythmic movement. And in diverticulitis, there's a thinning out of it. Tissue changes sometimes due to damage, sometimes autoimmune disorders. But when those pouches thin out, they could potentially burst, right? Maybe the more common one is appendicitis. Okay, so the little appendix right here on the bottom could swell up with bacteria. And then because it's left untreated, causes you to have a backup of stool, leaving you to have a lot of pain. And by the way, in case you didn't know this, if you had appendicitis, right? So when this appendix gets swollen up, if you were to press down on the counter section, so if appendicitis is right here, right lower. If you were to squeeze on the left lower, and the moment you let go, and there's pain in the patient, that's appendicitis. If you were to have it, you would not be able to do that. You would not be able to jump, or the moment I let go of my hand, you will feel pain. So in case you're ever curious, let me just pause this real quick. Approach. Let's say you push your hand down over here, right on the X. Let me use that color. Let's say you put pressure applied on the orange spot right here. It presses and pushes the sigmoid and shifts some of the small intestines against that tiny little appendix on the left of the image and causes you to feel the pain and disturbance. Within the teni coli, these bands of longitudinal smooth muscle, we have three subdivisions. We have the mesocolic tenia. This is what anchors the transverse colon and the sigmoid colon. And then the omental tenia is what binds over the omentum. It's not shown here. And then the free tenia is the one that binds to the back region over here. Looking at the picture of this image, you can't tell which ones are intraperitoneal and which ones are retroperitoneal, right? Any guesses? So look at the picture. Can you guys guess which one is retroperitoneal? Right. So if you look at the picture, you might be able to tell, right? It goes up, and you see how the transverse colon comes forward. You guys see that? It comes forward, and it hangs over. Then it backtracks down to descending. So your ascending and your descending is what? Retroperitoneal. Your sigmoid, let me use another color. Your sigmoid, I'll use blue sigmoid. Your transverse are intraperitoneal. Trick one for everybody. How about the rectum? Anybody? What do you guys think? Is the rectum intraperitoneal or retro? Or is it a mixture? Okay, this one's kind of hard. So if this is one of those that we'll get into this one next week, but the lower two-third portion, okay, the lower two-third portion of your rectum is actually retro. The upper proximal part where it junctures is intra. Okay, so this one's a little tricky, but it anchors, the upper part is towards the interior, the lower part is in the posterior. So it actually curves a little bit. The curvature that you can't see on the image provides valves inside, and the valve is what holds your feces. So when you eat a lot of food and it builds up and you feel the gas and you feel that disturbance, that kind of pressure building up, that's when you have the urge to go use the restroom, right? The defecation response. And that causes your external sphincter to relax, and then you feel good, you squat, and then there you go, take care of business. All right, so over here, we have then the cecum and the appendix. So appendix is that little pouch right there filled with bacteria, of the vestigial structure, and then the cecum is that exit point. So right here, we got the pouch right here, the cecum. As far as the cecum goes, this is a blind pouch about 7.5 centimeters in length. The key structure is that it does not contain any mesentery at all, and it does have a little small opening called the ileal orifice. This is the lip between the ileocolic lips right here. So when it comes in, you can see this opening. So the ileal orifice is right here, opening, and this is the opening to the appendix. The thought of the appendicitis is when there's bacteria that accumulates over here, causing it to be improperly regulated, goes in, overgrows, and causes a bursting. There's also papilla, and this is important because you don't want to have reflux of the contents from this area, right? Because at this point, you've already absorbed all the nutrients from your bolus. Whatever is going here is going to become what? Feces. Okay, at this point, maybe a little bit of water retention, a little bit of minerals coming out, but at this point, whatever is going through your colon is going to become waste. And so you want to make sure it's going one way. And then the appendix is a blind pouch, about 6 to 10 centimeters in length. It does contain some lymphatic tissue, vestigial structure that is believed to be at one point functional and then it regressed. So what I want to show you here is the key. I'm gonna zip through some of the arteries because I have a nice chart that overlines which ones goes where. But the arteries for the cecum appendix is going to be your ileocolic artery. It overlaps with the cecum, It also has a little bit of your descending colon as well, so there's a little bit of branching there. And then the appendix is dedicated to the appendicular artery. So in the cases of a surgical invasion, right, let's say you have appendicitis that bursts open, and if surgeon needs to go and suture, right, to reduce the bleeding to that area, you would ligate which artery? Which artery would you ligate to reduce the blood flow to the appendix? Appendicular artery. Okay, so some of these arteries, the names just go with it, which is kind of nice. The colic ones, remember, right side is going to be for ascending. So right is ascending, left is descending. Okay, right is ascend, left is descend. Cool. So let's take a look at a couple more arteries. For the colon, we're going to have the ascending transverse sigmoid. We also talked about it in circles, the small intestine. One little note that I want to highlight is about 25 to 30%, that number could vary a little bit, percent of the individuals of the population, you will have a slightly shorter mesentery that covers over the ascending colon. So not everybody is the same, and there are variations across populations. Okay, so that is one key point I wanted to highlight. As far as the arteries goes, the ascending is going to be ileocolic, so ascending up is mostly going to be right colic. There could be some sub-branches from the ileocolic as well. Okay, so that's the key artery. On the right side, I just want to show you the picture. So you can see this is the main abdominal aorta. Everything comes from your abdominal aorta. And as it comes down, we have the superior mesenteric. And then we have the inferior mesenteric. Up on top, that's not shown here, will be the celiac, will be up here. And then they then sub-branch into the tinier branches. Right colic right here. This one is the one that goes to the ascending. And then the left colic will be for descending. Transverse colon will be the middle colic. So right here, middle colic. Okay, so don't be intimidated when you see this picture, right? Just a lot of different subvessels. I think it's valuable to know the origin, and I also think you need to know the main branch of the structures, right? So the appendicular, right colic, middle colic, transverse intestinal artery. The rectum is pretty easy as well because you have the superior rectal artery, middle rectal artery, inferior rectal artery. The artery literally tells you what it supplies. There's a few of them that they don't, but majority of them they tell you exactly what it does. So nothing too tricky over here. As far as lymphatics goes, most of the name also mirrors exactly those arteries. So for the major regions for the ascending, you have the epicolic and pericolic nodes. They drain upwards, right? So the lymphatics go up, whereas the blood flow goes down, okay? And then it drains through the ileocolic to the intermediate right colic, and then you go into the superior mesenteric upwards. So just remember, instead of having the origin from the big vessel to the small one, the lymphatics go from the small back to the big one. It's the reverse flow of the fluid. We'll go over lymphatic and lymph nodes next week as we go over the spleen, but just remember it's an opposite direction of flow. All right, transverse colon, the main iconic structure that I want to point out is there is a little flexure called the left colic flexure. This is where it bends over from the ascending colon to the transverse colon. So right here, this juncture right here that I circled. And this region is slightly less mobile. It's important to be aware that this region is going to be intraperitoneal, hangs in the front. And oftentimes, diverticulitis, when you hear about the outpouching, most of the time it happens in your transverse. This is where the pouching occurs. And hence, as a result, you have this rebound tenderness. That's whenever you push down, putting pressure onto a spot on the lower GI, and you let go. When you let go, the pain arises. That's called rebound tenderness. And that's because it swells up, and then you squeeze into it, so you're putting pressure, and then you're creating a little bit more tension. Now you let go, that pain detection occurs. Over here, just like the stomach, what do you guys notice with the transverse colon? So if somebody was hyperesthetic, a bigger build, slightly bigger abdominal cavity, what does this transverse colon look like? Is it pushed upwards more or dropped further down? So on the left-hand side, what does it look like? The transverse colon. Slightly elevated, okay? So again, for folks that have a slightly bigger build, your transverse colon is elevated a little higher. And if you are a slender build, the transverse colon actually dips down slightly below L4. So when you are trying to palpitate or test your lower GI, depending on the build, you would need to know where you put your finger. Okay, you guys see that? So look over here, L4, it's above L4 in a hypersthenic. It's below L4 in an asthenic. Everybody good? So these are, again, in the practice of things, that's where it's valuable to know that certain body types will have a slight variation in the location of the organ. All right, and then let's go on. So over here for the transverse colon, we have the middle colic artery. There might be some branching that comes from the right and left colic arteries via anastomoses. This is the part that I said, I'm not going to ask you all the different arteries. I'll always only ask you the main one. Okay, just the main one. All right, so it won't be too bad. Let me just quickly jump around. Some of these slides are a little extraneous. So over here, I have, here, let me see, I think I have it right here. Actually, you know what? I don't have it here. Oh my gosh, okay. I'll put it up on the screen. So let me show you guys real quick. I can post this on Brightspace. Let me show you this little cheat sheet for all the blood vessels. Okay, this one will be nice. So I'll put this one up. I didn't include this one because this is the one I use for the COM program, but I think this will also provide some value and for studying. Right here, this is a quick cheat sheet. So I have the artery name on the far left, and then in the middle, I have the origin. In the far right, I have the target of the structure. Okay, so this covers all of it. This is not everything. This is the main one. So in some cases, there might be a little bit of overlap. So if you look over here, intestinal artery, the main origin is what? Superior mesenteric. And then it supplies all the way to the jejunum and the ileum, right? Middle colic goes to your transverse colon. Right colic goes to your ascending colon. Ileocolic goes to your ileum, cecum, and ascending colon. So you'll see right here that intestinal branch may have a little bit of ileum, but also the ileocolic may also have ileum as well. So there's some that have a little bit of overlap. This is a helpful, I guess, cheat sheet. So when you're reading it, instead of looking at a picture, getting a little bit confused, or looking at context, it gives you a quick snapshot. The appendicular artery, which we covered, goes over to the appendix. The inferior mesenteric is the subbranch from the abdominal aorta. And then on the bottom here, we have the left colic for descending. Sigmoid, we have descending and sigmoid. So this is another one where in some populations, the sigmoid may have a subbranch to the descending. And we'll go over the rectum next week. That's why I didn't have it. I think I left this one for next week because we're going to go over the rectum for now. But instead of going through the 5-6 slides of all those different vessels, this is a quick way to get it down. All right, so I'll post this up next week on the Brightspace so that we have it. But the one that you have right now does not have this one. All right, so let's resume back, and we're going to do a little bit on the liver and go over the gallbladder, and then we'll do some of the hollow stuff so you can see it. I'll probably say one of the best HoloLens in terms of experience is this one. So out of all the ones that I've done, I think GI with the HoloLens makes it really good because you can see the tubes and you can actually walk into it and look at how the tubes look. You'll also be able to see the valves in the rectum, which is something that almost you can never see in a cadaver. It's always like collapsed. There's a lot of gunk in there. This one's really clear. Okay, so to take a look for sure today, the HoloLens value is pretty high. Okay, so promise that. Go back to. These are all the sessions. I just got to find them. Not the right now. You got content for days. All right. That's a good one, Jason. All right, cool. So let's get through all the above. Yeah, it's okay. It's all good. It's Saturday morning. So let's talk a little bit about histology. So for the next 5 minutes, I want to quickly zip through a little bit of histology for you, just to show you what we're looking at, differences in large intestine, small intestine. And it's important to know that there are distinguishing features that make them different. The first image that I have here is small intestine. Okay, so on the screen on the right, just don't worry about any of the words. On the right here, one of the key hallmarks is number 1, villi. Okay, you'll see a lot of these hair cells. This is a pretty good zoom of the brush border cell. Brush border is a term used to describe the structure as a result of the lumen of the small intestine. The small intestine's main job is to maximize surface area to absorb, right? Because you ate the food. Now you want to get all the macromolecules, the carbs, the proteins into the body. So you want all the food product to interact with the villi. On top of the villi, we have another set called the microvilli. Okay, so it's a villi on a villi. So it's a hair on a hair. And the brush border is what contains those enzymes. But you can see right here that there's globule cells throughout, these little kind of round, hollow cells, the globule cells. And we also have the glandular cells in the middle. So some of these longer ones are more elongated are glandular cells. That image compared, this is the same thing, compared to this image, what do you guys see? So I want to show, just look at the picture. Over here, what do you see, or what do you see in the previous cell? So this image right here. So I want you to look at this cell, and then look at this cell. All right, what do you see here in this image that you don't see over there? So look over here, okay, again, look at the villi, look at the globule cells, look at the glands, look at the shape, overall shape, and now compare that to the cell. So what are probably the 2 main things that you don't see over here? You don't have any villi. So you don't have the villi nor microvilli. So those 2 things are not there. And there is one kind of cell that you may have heard, may have seen, called a pineth. Okay, so that is one of the only cells that did not talk about on this chart. So on the mnemonic that I provided you, there's one kind of cell inside your small intestine that is unique. This is called pineth cells. The pineth cell's main function is to produce a lysozyme. Lysozyme is this antibacterial cell wall component that helps you have this immune-based function. And when they stain the actual intestine, they can stain these pineth cells because each of these cells contain a supranuclear vesicle. So these are unique because they have these little red specks in the upper surface of the nucleus. These are the pineth cells. They're usually at the bottom pits of the gland. Okay, so the 2 major structures that distinguish between the large intestine and small intestines is the pineth cells and the villi microvilli. So when you're looking at histology, you're like, what kind of a cell am I looking at? If you see the villi microvilli, and also do you see pineth cells? Okay, those are the 2 key features that you should be aware of. And then I just want to show you, this is what the large intestine looks like in a real visual. So you'll see the globule cells littered all over. There's no big invaginations. There's no dips. You can still see the integrity. Some of these crypts are still kind of long. These are the glandular cells right here, these big elongated glands right here that I'm circling. And then surrounding it are the tiny globule cells. Right? The globule cells tend to be more round. The gland cells tend to be more elongated. So when you're looking at the picture, glands are tube-like, stretched out, more cylinder, more oval shaped. Globule cells are more round and oval. Okay. All right. So that is the key histology between large and small intestine. The final chunk of today's talk is going to be on the liver. Okay, so we'll go over the liver, briefly talk about some of the ligaments and the function, and then we'll go over the bile briefly, and that'll be it. Okay, so for the liver, main function is that it has a number of functions: detoxification, metabolizing drugs, producing certain kind of albumin proteins, globulins. But the function we're focused on today is on the composition of bile. So bile contains certain salts, lipase, bicarbonate juices, but its also function is to produce the cholesterol, to emulsify the fat. And that gallbladder is the storage component for the bile juices. Okay, you can see on the image here, it's tucked posteriorly behind the liver. In the cadaver that I have provided, you'll see the gallbladder actually dangling out because of the dissection. So they actually opened up the liver just a little bit so you can see the green gallbladder location. The liver is organized in a set of organization called hepatocytes, and the lobules are these big kind of hexagonal structures that contain what they call the triad. We have the bile ducts. Shown in green, we have the portal veins, and then the hepatic artery. Okay, so the bile ducts drain downwards, whereas the blood flow goes upwards. very similar to lymphatics. It's opposite flow, but you can see it's a kind of a hexagonal, pentagonal shape, and then within the lobes. I'll have a zoom up in a second. Key features here from different functions is the hepatic portal vein brings all the nutrients. It also provides the ability to metabolize the waste of hemoglobin, so conversion into bilirubin from the GI system. Then you promote the metabolism of protein, and also the movement of glucose and fats, urine production, detoxification. The function goes on. Okay, so it's one of the largest organs in the body. It has so much key functions, and it is also palpable when you take a deep breath. So you can feel the border of the liver just by inhaling in and taking your finger and pressing against that sternocostal space. You can feel the edges of your liver. All right, so let's take a look. So within the liver, some of the key anatomy includes some of the structures and ligaments and areas. We'll go over a couple of the ligaments, and then I'll show it to you during the HoloLens. But we have a falciform ligament on top. The falciform anchors the liver to the anterior cavity. It also uprights, holds it. Within it, you also have the ductus venosus. That's the remnant of the fetal umbilical vein. Okay, so there's a ligament that is the remnant from the fecal umbilical vein, because during the infant development, what happens? Your whole lung and liver isn't quite functional yet, so you're moving the blood from the placenta directly to the heart. Okay, so that there's a little remnant of that ligament as well. One of the regions I wanted to point out here is the number 3. This is the supraphrenic recess. This is a region in the retroperitoneal cavity. If you look at this picture, I know it's really small, but you can see the liver has many, many areas. There's a gastric area that the stomach sits. The stomach sits right into it. There's it. We have the renal area where the kidney touches. We have the colic area where small intestine touches. We have the other colic area, and then we also have the kind of middle region, which is the caudate lobe. The caudate lobe is truly the bisecting plane. What's important about the falciform ligament is this divides your right lobe with the caudate lobe. So it's a bisecting plane between the two lobes of the liver. If you look at this bottom picture, this is anterior. You have the right lobe and the left lobe. Everybody see that? Oh, let me zoom in a little bit. Nope, I can't zoom in. Oh, actually, I can't. Let me just zoom in. I'll zoom out. Okay, so tight. Can you guys see this? Okay, so there's the right lobe on the picture, which is the left side, but this is anatomic position, so my right, and then the left lobe on the right side of the image. The border on the lateral right border is called the apex, and over here the gallbladder sits behind the right lobe. Okay, so that's something to be mindful of. It's not symmetrical. And then if you zoom to if you go to the bottom, actually this is a better picture. Right, so this is a posterior view. And you can see all the different lobes. We have the caudate lobe right here, the right lobe right here. And then we have the top part of the caudate lobe, bottom part of the quadrate lobe. And then we have the left lobe right here. Okay, so there's 4 main lobes. And those ligaments that I just pointed out bisect the liver in different planes. So when you're doing a liver biopsy, or if you're going to have to donate your liver or cut the liver, whatever you're doing to the liver, these ligaments give you the boundaries of where they're at. Okay. So we'll zoom out just a little bit and highlight some of the key structures. So let's go back one more time. All right, so apologies for all those lines. So the hepatorenal recess, that's a renal small pouch where the kidneys are going to sit. This is also known as the Morrison pouch. And then we also have the hepatoportal triad. So the term portal hepatis and portal triad relates to the set of 3 vessels, your hepatic portal vein, hepatic artery, and also your bile duct as a 3-unit set. Okay, so they come together. And then key ligaments include your falciform ligament. This is what separates the right lobe from the left sagittal fissure. The caudate lobe, which you talked about, there's a posterior and a superior. The quadrate lobe, there's a slightly anterior and inferior. And then we also have the round ligament. This is the remnant of that umbilical. The ligamentum venosum, this is the remnant of the ductus venosus. So the ductus venosus is the bypassing of the blood from the placenta to the lungs. Okay, so that's the one that passes through. And then these are all at one point a vessel. The vessel then regresses in and becomes obliterated into a ligament. Okay, so those are probably the 2 key ligaments that I would like for you to see. And you'll see this in the HoloLens today. But those are the 2 you want to look for, right? And then let's keep going. One more slide. This is a pretty cool image. So when the liver is kind of broken out to the lobes, this is a color code. Each of the lobes or substructures are then labeled with a number. So you have 2, 3, 4, 5, 6, 7, 8, and 1 is in the middle, in the front. Okay, so you have the subdivisions of the 8 sections of each segment. And the reason why it's shown this is because each of those lobes has its own blood flow, right? One of the most extensively supported, because when your nutrients come from their GI system, the very first organ that gets the dibs is your liver. Your liver has to process all the nutrients first before it goes out. And over here, you can see the passage. So over here, I have some of the key vessels. I don't have the specific names, but as a snapshot, 70 to 80% goes through your portal vein. 20 to 25% comes from a hepatic artery. On the right side, if you want to subdivide it, you have the gastric branch, mediastinal branch, celiac branch, hepatic branch, cystic branch, phrenic branch, lumbar branch. The nodes also match pretty well with the arteries. We're not going to go into all the details here, but just know that they all collide into your portal artery and portal vein. And that's where all the nutrients go through. It is also important to know that there's a range for different populations for the lymphatic drainage. So 20 to 50% can drain into the thoracic duct, and that could vary. Right? Some people have a little bit more that goes directly in. Some people have less. All right, and I'll stop there for the liver. Any questions on the liver? Okay, so let's quickly go into the bile, so the gallbladder. So the gallbladder is a tiny little structure that sits on the posterior side of the liver. And as far as the anatomy goes, be mindful that you do have a fundus, just like the stomach. We also have a body, and we also have a neck. Okay, just like the pancreas, the stomach, the gallbladder, we have those same subdivisions. As far as the tube goes, we have the cystic duct that then joins in with the common hepatic duct, and that then leads into the pancreatic duct, opening to the ampulla of Vater. We went over this. This is the first opening in that first section of the duodenum, right? That little pouch where the juices come in. So you have 3 junctions: the common bile duct, pancreatic duct, cystic duct. And they all come together to join a little opening to allow the juices to come in and flood. The arterial supply is going to come from predominantly the pancreatic duodenal artery, and then the venous drainage is the same, pancreatic duodenal vein. And you can see right here that the body in the neck is pretty closely tucked underneath the liver. In a real cadaver, it's not perfectly underneath it. Okay? It might drop down a little bit if you have a swollen gallbladder or gallstones. Then that could shift the gallbladder slightly to be a little bit opposite.